So welcome to our presentation, the latest updates in Alzheimer's disease research presented by the Michigan chapter of the Alzheimer's Association and the MADC, which is the Michigan Alzheimer's Disease Center at the University of Michigan. Please feel free to type your questions for Dr. Roberts in the Q&A. You should see the little bubble at the bottom of your screen for Q&A. And I'd like to welcome our speaker this morning, Dr. Scott Roberts. Scott Roberts, PhD, is a professor of health behavior and health education at the University of Michigan School of Public Health, where he directs the certificate program in public health genetics and co-directs a dual master's degree program in public health and genetic counseling. Dr. Roberts conducts research related to health education and support services in Alzheimer's disease and has served since 2001 as co-principal investigator of the NIH-funded REVEAL study, which is a series of randomized clinical trials evaluating the impact of disclosing genetic risk information to individuals with a family history of Alzheimer's disease. Prior to coming to the U of M, Dr. Roberts served as co-director of the Education Corps in the NIA-funded Boston University Alzheimer's Disease Center. He now directs the MADC's Outreach, Recruitment, and Education Corps. Please welcome Dr. Scott Roberts.
All right, well, thanks so much, Susan. It's a pleasure to be here today. I'm a big fan of the Alzheimer's Association, having worked with the organization for about 20 years now, dating back to when I was at Boston University. So always appreciate the opportunity to speak with folks and appreciate everybody coming out on a sunny Friday here. So as Susan mentioned, I'm going to be trying to give you all some of the latest and greatest in terms of Alzheimer's disease research findings. And as she mentioned, I represent our Alzheimer's Disease Research Center based at the U of M, but also including some strong collaborations with Michigan State and Wayne State. So we like to see ourselves as a statewide center. So just before I get started here, since I'll be talking about some new medications in the pipeline and other commercial products, wanted to mention any financial disclosures. I have no financial conflicts to disclose, and here is a listing of some of the sources for my research support. But just to give you all an overview of what's going to be covered today, we're going to start with just some basic background and the public health significance of Alzheimer's and related dementias. I'm in a school of public health, so I think it's important to talk about the significance of Alzheimer's to broader society. And then the meat of the talk will really be, as you can see here, just a focus on some areas where we see a lot of active research. So I'll be talking about imaging and biomarkers, clinical trials, risk and protective factors, and some lifestyle interventions. And then what I'll close with is just some information for you in case you or someone you know might actually be interested in joining a research study yourself. So I'll let you know a little bit about what's going on at our center in that area. And then we'll try to make sure we have ample time at the end for some Q&A. Although, as Susan mentioned, if you do have some burning questions as I'm going through the talk, you can feel free to put those in the Q&A or the chat, and I'll try to address those as we go. All right, well, let's get started here. So as I mentioned, I wanted to start with some background information for folks. And just to make sure we're all on the same page here, I like to start by reminding us when we talk about Alzheimer's, it's just one of several different types of dementia. So sometimes people, think these terms are synonymous or don't quite understand the distinction, but dementia, is the broader umbrella term to describe a range of symptoms associated with cognitive impairment. But of course, there can be many different underlying causes of dementia. And so Alzheimer's is the most common type, but of course, there's many others as well. And some of you may know about this, vascular dementia, Lewy body, frontotemporal, et cetera. So sometimes during the talk, I'll be talking about Alzheimer's in particular, but then other times I'll just be referring more broadly to dementia. And to make matters even more complicated, sometimes we know that actually folks are dealing with multiple processes in the brain that might be characteristic of different types of dementia. So it's possible, for example, that someone could have both Alzheimer's pathology and vascular pathology happening at the same time in the brain. So hopefully that helps just from a definitional standpoint. But let's talk about some of the public health significance of Alzheimer's and related dementias. And for this section, I'm going to be relying a lot on a great resource that I wanted to let you know about. So the Alzheimer's Association puts out on an annual basis this facts and figures report. So it's actually, you can download it for free on their website. So this just came out, I think, about a month or so ago. And they do a really nice job of compiling the latest statistics in terms of the prevalence of Alzheimer's and related issues. And just to let you know, I'll be talking about a lot of these statistics, and some of them are pretty sobering. But of course, want to recognize that it's not always doom and gloom when it comes to this condition, that a lot of folks are living successfully dealing with this and still contributing and finding lots of meaning. So even though I'm going to be kind of talking in this more dry stats mode, I certainly don't want to lose sight that behind all of the data are people dealing with this condition. So Alzheimer's, as many of you know, is a very common condition. So it's estimated that now over 6 million people have Alzheimer's dementia in the US. So that means about 1 out of every 9 older adults could be said to have Alzheimer's dementia, which is a pretty striking number. And given that age is an important risk factor, the vast majority of people with Alzheimer's are age 75 and above. And interestingly, about 2/3 are women. And so we don't usually think of Alzheimer's as a women's health issue, but you could argue that on the basis of that statistic, I believe. And thinking closer to home here in Michigan, it's estimated we have almost 200,000 folks living with Alzheimer's in our state. And given the way the trends are going, that number will increase by tens of thousands just in the next few years. So I think all of this is to say that it's a really important public health issue, and that we need to be thinking about how are we going to continue to address this and perhaps even increase our efforts. COVID-19, of course, has been hard on all of us, but has been especially hard on families dealing with Alzheimer's. You can see not only from this statistic talking about increased deaths from Alzheimer's, but of course, as many of you may know, for those living in nursing homes or other institutional facilities, it's really disrupted the ability for family caregivers to be able to connect with their loved ones. So really a lot of challenges in this COVID era, but hopefully with things looking up on the vaccination front, that there's some room for optimism. Just in thinking about these trends nationally in terms of the prevalence of the condition, you can see this graph shows how if we aren't able to find any new therapies that might delay onset or even cure the condition, if we keep going at our current pace, these are the expectations in terms of numbers of folks with Alzheimer's dementia. So it's projected that we might go from over 6 million today to even more than double that number by the year 2060. And you can see also from this graph that the proportion of people with Alzheimer's who are 85 and above is also expected to increase dramatically. So given that portion of the older population, often called the oldest old, often has a lot of other medical issues to deal with, you can see how it might be a pretty complicated picture for our healthcare system to contend with these kinds of numbers. So again, another reason for us to think about how are we going to address these concerns. That facts and figures report that I mentioned earlier did have a special report focused on racial and ethnic disparities. So unfortunately, as is the case with many other common health conditions, we do see some notable disparities by racial and ethnic group in the United States. So for example, older Black Americans as compared to their white counterparts are 2 times as likely to have Alzheimer's disease. Hispanic Americans also at elevated risk. And then very discouragingly, this report did a special survey across dementia caregivers and found that regardless of what racial or ethnic minority subgroup one was within, that those dementia caregivers were reported reporting a lot of perceived discrimination in their encounters with the healthcare system. So you can see the numbers here, whether it was Native Americans, Black Americans, Hispanic Americans, or Asian Americans. All of these numbers are pretty high, and about 50% or even more saying that they had experienced some kind of discrimination on the basis of their race or ethnicity. And so I think it points to the need for us to try to do a better job in order to try to make that experience more positive for caregivers, and to improve our services in a variety of ways. Because it's not just once you're in the healthcare system, we know there's a lot of barriers even to getting to care by racial and ethnic subgroup, whether it's access to facility that has expertise in dementia, or insurance coverage. These kinds of things are important barriers that exist. And so as a result, I think we see that there are often times where folks will be even reluctant to come forward for care in the first place for memory and thinking problems, or if they do, it's often when the person with dementia is already at a moderate to severe stage. So a lot of room for improvement, I think, in terms of addressing racial and ethnic disparities. But part of the first step of the problem is really just characterizing what we're dealing with that could hopefully help guide some of our efforts here. Let's talk a little bit more about caregiving more generally, and many of you may be either currently caregiving or have cared in the past for someone living with Alzheimer's or related dementia. So you're not alone. We have over 11 million caregivers in the US estimated to provide care in the past year. Most of these, about 2/3, live in the community with the person with dementia. And again, this gender issue comes up again in that 2/3 of dementia caregivers are women. About 30% are estimated to be age 65 and above. So again, some of those caregivers are often dealing with their own physical health challenges. And then about 1/4 can be said to be part of this sandwich generation. That is, they're in this dual role of not only caring for a loved one with dementia, but also raising children under age 18 in the household themselves. And so that, as you can imagine, that can be a challenging position to be in, to be trying to provide care at both levels. And I don't mean to imply that caregiving can't have its rewards or can be very meaningful in a lot of different ways. For sure, I don't want to suggest that. But we do know that caregiving can have a lot of challenges. It's estimated that 15 billion hours were provided, and that caregivers themselves sometimes deal with emotional health or financial strains. And so this statistic, I think, points that out as well. So as a result, I think we're trying to think about, I'll talk a little bit later about caregiver interventions, but we're trying to think about what can we do to provide services to support caregivers, whether it be education, respite care, other kinds of practical skills in order to help them in their caregiving roles. Going along this lines of cost to society, you can see that the costs of care for Alzheimer's are pretty dramatic, over $350 billion this past year. And again, those numbers are expected to dramatically increase over time. And this is for a variety of reasons. You can see the different ways in which costs might be incurred, whether it's hospital stays, nursing facility stays, home health care needs, or nursing home care, adult day services. These all add up, and you can see that a lot of these costs are borne by Medicare, some by Medicaid, but a lot of times it's families paying out of pocket as well. And so these are some pretty notable financial costs that I think, again, make the case that we should try to do more in investing as a society in improvements to quality of life in a variety of ways. And fortunately, on the positive side, we've seen some of these investments being made in recent years. So here's a graph that shows the level of federal funding through the National Institutes of Health, which is the main federal funder of Alzheimer's research. And particularly within the NIH, the National Institute on Aging is the main institute there that funds Alzheimer's research. So through the advocacy efforts of those at the Alzheimer's Association elsewhere, we've seen some dramatic increases in recent years, many times increased just in the past decade, such that in 2021, we saw over $3 billion allocated to Alzheimer's research just at the federal level. That's not even to mention, all the research that's being done by private industry through pharmaceutical companies or foundations. I know Bill Gates himself has given tens of millions of dollars, given his own family history of the condition. So on the positive side, I think we're seeing a lot of investment in research in a variety of domains. And I'll be trying to summarize some of that research here with you today. So that's the good news. I think we also, though, need to take the long view here. Here's a look at Alzheimer's disease federal funding compared to some other major health conditions. We've seen cancer funding dramatically increase ever since the Nixon era, where the war on cancer was declared. HIV/AIDS really picked up in the 1980s. And so Alzheimer's, only recently have we started to see this dramatic increase. And so I think remembering that, because obviously in cancer and HIV/AIDS, we've seen some dramatic breakthroughs in terms of improved therapies over the years. So hopefully we'll see some similar results in terms of Alzheimer's disease research funding as well. So that hopefully gives you a little bit of a sense of some of the public health significance of the condition. But now I want to shift gears a little bit and talk a little bit more about this concept of imaging and biomarkers, which some of you may have heard about. So when I mention biomarkers for Alzheimer's disease, of course, the two classic examples are plaques and tangles that start to develop in the brain. And so these amyloid plaques and neurofibrillary tangles have been the hallmarks of the disease ever since Dr. Alzheimer's himself back in 1906 identified these. And so those are the ones we often think of, but there are others as well that I'll be talking about, including inflammation in the brain, what we call neurodegeneration, that is brain atrophy or shrinking over time of certain regions of the brain. So particularly those that are involved in memory, like the hippocampus in the brain, you might see on a neuro image some atrophy over time in that area. And of course, there's a lot of different ways to assess biomarkers. So it used to be the only way we knew if amyloid plaques and these tau tangles were really present in the brain was to do an autopsy after the patient had passed away. But an exciting development, we've seen a lot of other methods being developed in recent years, whether it's through neuroimaging like PET scan or MRI. You can also detect biomarkers through what's called a lumbar puncture. You inject a needle into the lower back and extract cerebrospinal fluid. And then there's even blood-based biomarkers now that are being developed. So the question is this a replay of the presentation? So yeah, this is basically, for those of you who were here Wednesday, this is pretty much the same information I covered then. I think the idea was to have two versions for those who couldn't make it on a weeknight, that maybe this Friday morning time was preferable. So if you did see me on Wednesday, it may not be worth your while although certainly there might be different questions that come up compared to the Wednesday presentation. All right, so that's just an overview of some of the biomarkers that I think are important to think about in Alzheimer's disease. And I think what's happened is the Alzheimer's disease continuum here represents the stages that people go through if they ultimately do develop dementia of the Alzheimer's type. And I think we're all more familiar with these stages on the right. So once people actually start to experience cognitive symptoms like loss of memory or other challenges. But in recent years, we've seen the ability to identify folks in these earlier stages. So some of you may know about mild cognitive impairment, this stage where people might have mild memory symptoms, but they're still able to pretty much function as usual. And we've now, though, moved to this idea of preclinical AD. So this notion that even when people have no symptoms whatsoever, they're totally cognitively normal, there may still be things going on in their brain that might herald the ultimate development of Alzheimer's disease dementia. So that's where some of those biomarkers that I mentioned, we can actually detect them, maybe even decades ahead of any symptoms. And so I think that's been exciting because it just suggests we might be able to intervene earlier. We haven't had great success when we try to develop therapies once someone already has full-fledged dementia. So the hope is that if we pick up the presence of some of these biomarkers early on, then that'll give us a better shot of actually intervening and having some success in delaying the onset of the condition. But it gets tricky because some of these biomarkers, just because you have them present, doesn't mean you're inevitably going to go on to develop dementia. A lot of people may have, for example, amyloid in their brain or even some tau tangles and are still ultimately fine and never experience dementia. So that's kind of where we are in terms of thinking about this continuum. But again, by trying to better define this preclinical stage, the hope is that we can have some improved therapies. So one question here from Linda is, what's my best estimate for when biomarker identification will become commercially available? And that's a good question. And in fact, as I'll talk about, some of these already are available. I'll be talking about amyloid imaging that's actually done clinically now. And there's a blood-based biomarker that is being offered commercially. There's some controversy over whether it's truly ready for prime time. But I guess the short answer is we already are starting to see some of the use of biomarkers, particularly in those who already do have some cognitive impairment. So as I'll talk about, the use right now is to help maybe determine if someone has a dementia, which type are we talking about? And that's where these biomarkers might be useful in helping figure out, well, is it Alzheimer's or some other type of dementia that someone is dealing with? So good question there. So biomarkers are also key to this idea of one theory of the disease is this amyloid cascade model. So the thought, according to this, and again, some people might suggest that we don't know for sure that this is really how things totally work. But the general thought is that that in Alzheimer's disease, we see this predictable pattern of events over time. And that the very first signs of the disease are when these amyloid plaques do start to become deposited in the brain. And again, this often happens maybe 10, even 20 years ahead of any symptoms. But then ultimately, if that amyloid deposition gets to a point where it's pretty significant and in a lot of different regions in the brain, we might then start to see a cascade of other events happen in the brain, such as inflammation might start to occur. And then that's where you might also start to see neurodegeneration, certain shrinking of different parts of the brain. And then that's when you start to see as well these tau tangles start to form, those neurofibrillary tangles that I mentioned earlier that are another hallmark of the disease. And then things continue to progress where we actually then start to see cell death. And once you get later in this process, that's when you start to see the actual cognitive symptoms emerge and people start to be able to lose functioning. And so the thought is, if we can interrupt this overall cascade of events, the hope is then that's going to be the key to treating the disease. But as I'll talk about, it sounds good on paper, but unfortunately to date, we haven't had great success. And so some have suggested, do we need to revisit this idea of this quote unquote amyloid hypothesis as being the total key to treating? And do we need to think more broadly about maybe other aspects of this model and trying to intervene beyond just an anti-amyloid approach? But given that amyloid is so important, there has been a lot of focus on different ways of trying to detect amyloid deposition in the brain. And so one of these has been through amyloid imaging. And so you can see this is typically done through a PET scan. And you can see in the image, the person is going into the scanner. This would be after they've actually been injected with a radio tracer that would ultimately bind to amyloid plaques in their brain. And so after that tracer is injected, they go through the scanner. And then ultimately, if there is significant amyloid plaque presence in the brain, it would show up on these images. And you could see both the extent to which it exists as well as to where in the brain is it occurring. And so this was a dramatic development. University of Pittsburgh was key in helping devise this. And then ultimately, industry created some approaches that were FDA approved back in 2012. And so, as I was mentioning in the response to the question earlier, we do see amyloid imaging being used in clinical practice in some cases, oftentimes to assist with a diagnosis of someone who already has cognitive impairment. So the FDA did not approve this for use in people who do not have cognitive symptoms because it's unclear how predictive it is. As I mentioned earlier, people could have amyloid in their brain and never go on to develop dementia. Although there are a lot of people who are curious about their own status. And we actually did a study called the Reveal Scan study where we offered people the chance to learn what their amyloid status was, even when they didn't have any symptoms. But right now, that's not done in clinical practice, this idea of amyloid imaging if you don't have any symptoms. And even amyloid imaging in those who do have symptoms is not typically covered by Medicare. And so as a result, this major project was undertaken called IDEAS, where they were trying to figure out, well, just what is the clinical usefulness of doing amyloid imaging? So before we're going to cover this, this is a very expensive procedure, may cost several thousands of dollars. So Medicare, understandably, was like, before we're going to make this huge investment using taxpayer dollars, we want to make sure that it has some medical utility. And so they helped sponsor this major study of over 18,000 patients, where each of these patients had some kind of dementia, and the treating physicians were trying to figure out, well, what was going on that might help them make a more definitive diagnosis. And so in this IDEAS study, what they found was that the amyloid imaging was helpful in informing medical management. It did seem to make a difference, for example, as to what kind of medications might be prescribed. It also made a difference in terms of what kind of diagnosis was provided. So for example, a common occurrence was a patient might have a provisional diagnosis of Alzheimer's, but then when they did the amyloid scan, it might show that there really wasn't significant amyloid present. And so then the diagnosis might be changed to another type of dementia. And so we did see some utility from that standpoint. On the other hand, when you looked at some of these downstream patient outcomes, the scan did not seem to make a big difference in terms of ultimately, did the person with dementia have fewer hospitalizations or ER visits or outcomes of those sorts. So I think there is still a focus on trying to figure out under what conditions might it be useful to do this kind of imaging, and when should we have Medicare coverage. So there's another major study that's being launched with a more racially diverse sample that hopefully will provide some guidance. And so hopefully at some point down the line, we will see Medicare coverage of this imaging. And again, some of this may depend too on, will we have improvements in what we can actually offer patients with the diagnosis. So shifting from amyloid imaging, let's talk about another biomarker. I mentioned these tau tangles. They're another cardinal feature of Alzheimer's. As you might expect, there's now tau imaging as well. So this isn't as fully developed as amyloid imaging, but it's the same principle. The idea would be you inject a tracer, it shows up in the brain on a scan, and then you can see whether there's significant presence of tau tangles and where in the brain that might be occurring. So you can see in the image, the B image is the person who does have Alzheimer's and significant tau tangles in the brain, as opposed to the A image, the person who does not have that tau buildup. And so this is mostly done on a research basis, but we did see the FDA approve this fluortaucipir a year ago for clinical use of tau imaging. And so then the question was, the IDEAS study, is it looking at whether it makes a difference to caregivers who might find it helpful to feel more secure in the diagnosis and to judge potential medications and treatments? And there actually is a component that was kind of what we call an ancillary study. There was a group at Brown University that is conducting a caregiver-focused study as kind of a complement to the main IDEAS study. So I think they are looking at that. I don't know the very latest details there in terms of what they're finding, but I think that's a great point, is that this information is not only relevant for the medical providers, but also to the family caregivers as well. And so the lead investigator is Dr. Vincent Moore, M-O-R, at Brown University. And so maybe a quick Google search of his work might let you know whether any findings have come out recently from that ancillary study to IDEAS. But back to tau imaging, I think there's also excitement here that tau imaging can be useful. And so I think the future vision of care of Alzheimer's is that these will probably be done in tandem. It wouldn't just be just one or the other. But of course, the tau imaging is also expensive as well. And so we need to think about those issues in terms of costs of care. And so, and interestingly, tau is perhaps better correlated than presence of amyloid in terms of how someone is faring cognitively. So, and Deanna is asking the question of how far advanced is this patient? I don't know exactly in terms of their functioning, but I think it's, I don't know what specific stage this person is, but definitely at least at some stage of dementia, and perhaps even beyond the mild stages, because this level of tau is usually correlated with significant cognitive impairment. Whereas with amyloid, you might have somebody who definitely has a positive amyloid scan, but actually is still cognitively normal. That would be much less likely when significant tau is present. And very exciting news has been this blood-based biomarker approach. So I mentioned that these PET scans you have to go to a specialized facility, you have to have an expert reader, you have to have thousands of dollars. But if we could do some of this just with a simple blood test, you can see how that would be very advantageous. And so lo and behold, at last year's big international Alzheimer's Association conference, we saw a whole set of findings come out from different research groups using this p-tau217 biomarker. So this was a biomarker that could show up via a blood test, and it could detect the presence of tau in the bloodstream. And so the idea here was you wouldn't necessarily have the same specificity of information as on a PET scan as to know like where exactly in the brain it was occurring, but you would at least know, is there significant tau present or not? And so it was amazing, some of the findings of just how sensitive and specific this blood-based biomarker test seemed to be. And so in science, it's always nice when you have what we call replication of findings. So it's not just one particular study from one group with one sample of patients. These were findings that were coming from, there was a group in Sweden doing the study. There was a group in San Francisco, St. Louis. There was a study of folks in Colombia and South America, and they were all kind of pointing in the same direction, that this seems to be a very promising blood-based biomarker that's going to be able to reliably detect whether tau is present or not. So the idea here is that the blood test, and it seemed that whenever this p-tau biomarker test was positive, it also suggested that amyloid was also present as well. They seemed to co-occur quite frequently. And so the vision here is that perhaps you might imagine in the future a primary care doc even being able to do this kind of blood test. And if it came back positive, maybe that would suggest the need for more advanced study and more undergoing the amyloid and tau neuroimaging. But the first step could be the much cheaper blood test to see, do we even want to go down that road? And the question earlier was about commercial application. There is a company that's offering this test. I don't think it's the exact, I don't know if it's the exact P2 tau 217 test, but a similar test to see if there's presence of at least amyloid in the brain. And so that's been somewhat controversial. I think this field is split. Some feel like, oh, that might be a useful test, where others are saying, oh, it's too early. We really don't know enough about the meaning of what a positive test is for it to be done on a widespread basis. And so I think, even though I think right now the consensus is it's not quite ready for prime time in terms of clinical use, I think the hope is that before too long, we will be able to standardize some of these approaches and be able to see it translated into clinical practice. And then the question is the blood-based biomarker more sensitive than PET or not? Is reliable? I think the question, I think it does seem to be, at least from these data, very sensitive and very reliable. I think you not necessarily better than PET though. And I think the advantage of a PET scan over a blood test would be, the blood test would be more able to just tell you like yes or no, is the biomarker present? Whereas with a PET scan, you could actually see like, well, where in the brain is it occurring? Is it like, diffusely spread out, across, all different areas of the brain, including the areas that are typically associated with Alzheimer's. And so I think overall, if you had to pick one, you probably would want to do, the PET scan. On the other hand, as I was mentioning earlier, that this is going to be much, much cheaper and much more efficient and much more, you could do this, not at a specialized facility. You could do it in a broader set of clinical practices. And so I think there was such excitement about this that we really saw, and this made international news at last year's meeting, and you can see some of the headlines speaking to the game-changing notion of this idea of a blood-based biomarker. On a research basis, we've also seen these biomarkers are being used to as part of what might be called this ATN framework. And so the A stands for amyloid, the T stands for tau, the N stands for neurodegeneration. And so some have suggested, well, maybe we could be able to have more, subtypes of Alzheimer's disease if we use this kind of framework. And you might classify people as to whether or not, they're positive on these different biomarkers. And so you can see if you use this framework, you might have like, all these different categories. And perhaps the thought is maybe you would tailor your treatment according to this ATN framework, because you wouldn't want to use an anti-tau approach if the person is negative for tau, for example. And so the thought is this might be a more fine-grained way of thinking about classifying folks with Alzheimer's in the future. On the other hand, as I mentioned, a lot of people might be positive for these biomarkers and never go on to develop dementia. And in fact, it's estimated that if you use this ATN framework, that we would have 47 million people in the US would be positive on at least one of these biomarkers. And given that many of those would go on to develop dementia, we want to be careful about, we don't want to over-label people as having neuropathology if it really is not going to make a difference in terms of whether they experience ultimately any cognitive issues or loss of functioning. So we'll be waiting to see how this progresses. Right now, this framework is just being proposed on a research basis, but I did want to mention it given that, again, it's possible that this ultimately could guide clinical practice in the future. All right, so that's kind of my 2 cents on imaging and biomarkers. But given that a lot of these approaches are being used in medication trials, I thought that would make a nice segue to talk about clinical trials, where I know there's often a lot of interest. And just to remind us all, when we think about drug trials, in the US at least, they have to undergo this very rigorous approval process overseen by the FDA. And it goes through several phases. And so these kind of one builds upon another. An early phase 1 trial might be very small, maybe even 10 or less participants. The goal there would be just to see, hey, is this medication basically safe to use? And at what dose would we need to use it to make sure it is safely administered? So once you maybe establish that a drug is safe through the phase 1 trials, you would move to phase 2, expand the number of patients who might participate. Here's where you would often see as well a comparison group introduced. So, randomization, where maybe people would be randomized to either get the active medication versus the placebo control. And then in those phase 2 trials, you'd be able to say more about, well, is this drug beneficial or not? What are the side effects, if any? And then for the sake of argument, if the phase 2 trials are successful, you then move on to the final stage before formal approval, which is phase 3, which you would again be seeing these trials done in a much broader range of subjects, again, using a placebo-controlled trial is typical. And you would, through these larger trials, be able to say a lot more about, well, what's the overall risk-benefit ratio of the medication? And so any company trying to win FDA approval would ultimately have to submit data across all of these trials to the FDA, who then reviews it to determine should we allow this to be on the market and prescribed to patients with Alzheimer's. Unfortunately, and many of you may know this, we've been on a long losing streak in terms of clinical trials. So we haven't seen an FDA-approved medication specifically for Alzheimer's in almost 20 years. And this is not for a lack of investigation. Many major drug companies have spent billions of dollars, and we've seen about 40 consecutive negative phase 3 trials, which has been very frustrating for a lot of folks involved. This is the listing of the drugs that have been approved to date for Alzheimer's. Most of these are in a class that's called cholinesterase inhibitors. So that's the neurotransmitter. Acetylcholine is what they target. And so some of you may have had loved ones who are either currently on some of these medications or have been prescribed. And so they have shown some benefit, but it's relatively modest, as you may know. A lot of these medications may temporarily slow cognitive decline, but they're not ultimately going to be able to stop the progression of the disease overall. So that's why there's been a lot of focus. Can we do more than what we currently have available? And there's been some promising results from some medications. And so one interesting example is a drug called Angiocatamab. So this is one of those anti-amyloid medications that I mentioned earlier. So the idea here is this is actually a medication that would be administered intravenously. It's an anti-amyloid antibody. The hope is that it's going to be able to do this plaque busting, as you can see from this image here. And so what they found with the early studies of Angiocatamab, one of the phase 1 trials, you can see this image here shows that they, in the high dose group, they often found findings like this. So here's a patient whose initial amyloid scan shows a lot of presence of amyloid throughout the brain. And then they, gave the Angiocatamab, and over time you saw a year later a negative scan. So seemed to be able to clear out a lot of this amyloid plaque deposition that was occurring in the brain, as compared to the placebo, where you see pretty much comparable levels of amyloid. So that was very exciting. It seemed to be doing what it was designed to do in terms of clearing amyloid from the brain. But then the question then was, would that be enough to actually improve patients' cognitive functioning and quality of life overall? And so it's been a long and winding road, this Angiocatamab story. So I mentioned the findings I just showed you were from 2016, this phase 1b trial. So that was the good news. There were some safety concerns, though. There did seem to be a subset of patients who did have, for example, microhemorrhaging in the brain that posed some safety concerns. But overall, the news was good enough to proceed into the phase 2 and then ultimately phase 3 trials. So they launched these 2 major phase 3 trials known as Emerge and Engage. And unfortunately, though, Biogen is looking at the data along the way and with the Drug and Safety Monitoring Board. And they reported in early 2019, they didn't seem to think that they were going to have any chance of success. And so they said, well, we should probably discontinue the trials. We don't want to put our participants through any more risk if this is not going to be a success. And so they ended the trials at that point. But interestingly, they kept analyzing the data after that and ultimately said, hey, wait a minute, we think we may have jumped the gun too early here because we did find that in one subset of patients in one of these 2 trials, we did seem to see a signal that the drug might be working. And in the Emerge trial patients, they found that those who were getting the higher dose were showing less decline than the placebo group over time. And they said, well, given that we're in such need of improvement in Alzheimer's therapy, let's go ahead and apply to the FDA for approval of the medication. And the FDA allowed this, and they also encouraged continued additional data collection. But then ultimately last November, they had a meeting where their advisory committee reviewed the data that Biogen had sent them and suggested they didn't think it was sufficient for approval. But if you know anything about this FDA approval process, it's very involved. And just because an advisory committee gives an opinion isn't totally binding. And so this isn't the end of the story, although some feel like, well, this probably is not great news for this medication. But ultimately, what's going to happen is the final decision will be made actually just a few weeks from today. And so circle your calendars if you're interested for June 7th. That's when the FDA is planning to make its final decision. And so it's possible if they decide to approve it, we will have a new FDA-approved medication for treatment of Alzheimer's. And this would be the first of its class, the first of these anti-amyloid agents that would be approved for use. So stay tuned there. Another anti-amyloid medication that's been in the news recently is one called Denatumab. And you may have seen reports because just in this March, we saw findings in the New England Journal of Medicine. So this was from a phase 2 trial known as the Trailblazer study from a similar type of medication as Angiocatamab, also another anti-amyloid antibody used intravenously. And so you can see this graph here shows how patients in this trial did on their main outcome measure was something called this integrated AD rating scale that combines both cognitive and functional impairment information. And so you can see in this trial, they followed people out to 76 weeks. So, about a year and a half of being administered the medication. And they found that the Denatumab treatment group, we saw less decline over time as compared to the placebo group that was not getting an active drug. So you can see there's a clear split here between how the 2 groups fare over time. On the other hand, it's not like the Denatumab group is improving or staying stable. They're also declining over time, but it's just slowing the decline seen on this main outcome measure. And then interestingly, the other piece of good news from this trial was not only did they seem to have less cognitive and functional impairment over time than the placebo group, they also had greater reductions in amyloid and tau. So they were doing that amyloid and tau imaging that I talked about earlier, and also seeing that the drug seemed to have benefits from how the neuroimaging images were looking. So this was successful enough that this drug is now moving to phase 3 trials. And so perhaps this might ultimately be another medication that could be approved for Alzheimer's treatment. So that's kind of the latest on medications that are being tested in populations that have either MCI or early Alzheimer's dementia. some of you may be aware there are studies that are also being done in people who have no cognitive symptoms, who are cognitively normal, but because of either their genetics or their amyloid neuroimaging results, we know that they're at elevated risk to ultimately develop Alzheimer's dementia. And so some of these trials are pretty well known in the field, but most of these we haven't yet heard the kind of final word, are they going to be successful or not? So a lot of them, the people are still being followed. Because again, when you have a cognitively normal population, you often have to follow them over significant periods of time in order to be able to see whether or not someone would go on to develop any cognitive symptoms or not. So stay tuned on how these prevention trials might work out. And one example of a prevention trial that's actively recruiting now, including here in Michigan, is called the AHEAD study. So this is a trial where they are, again, using another anti-amyloid antibody. But what's nice about this study compared to some of the others is they've expanded the age range of folks who are eligible. So they've moved it down from 65 to 80 to 55 and above would be eligible. And so it would be a placebo-controlled trial following people for at least 4 years over time. And they have two related trials that they're conducting, one in tandem with the other. One is known as A3, one is known as A45. And the idea here is that they're using this amyloid imaging test at baseline to see, do people have any kind of significant amyloid buildup? The A3 trial has more mild amyloid buildup. They're calling it like an intermediate level. And then the A45 trial is with those who have more significantly elevated amyloid. So both of these trials are going to be testing out anti-amyloid therapies. And so, like I mentioned, it is possible to enroll in this, given that it's going on now. So I have some information at the end specifically that might be of interest if any of you know someone who might want to take part in this kind of trial. And just to sum up here, I think ultimately where we're going is, even though a lot of the focus now is on anti-amyloid therapies, as I mentioned earlier, there's a lot of folks who feel like, oh, well, we need to think about also developing medications that are going to target tau, or we also need to think about medications that might address brain inflammation. And so I think the thought is that ultimately what we might see is what we'd see in a lot of other diseases, that it's not just one medication, that it's actually kind of a combination of approaches, each targeting different processes in the brain. And so I think that's probably the most likely outcome if you had to predict, maybe a decade from now, what we're going to see. Linda's asking, studies looking at targeting something other than tau or amyloid. And yeah, I think there have been a lot of studies looking at kind of anti-inflammatory approaches. And as I'll talk about, there's a lot of lifestyle intervention trials that are kind of non-specific, but just might have a lot of different ways of potentially enhancing brain health. And so it's certainly not all the eggs are being put in the tau or amyloid basket, but some have critiqued the field for being too singularly focused on amyloid in particular. So let's shift from clinical trials and talk a little bit more about risk and protective factors for the disease. A lot of people are concerned about this. Unfortunately, there are some prominent risk factors that we can't really do anything about. And of course, you probably all know that older age is a prominent risk factor. And so you can see here, those who are in the 85 and up age range have much higher chances of having Alzheimer's than those in the 65 to 74 range. I mentioned women being at higher risk earlier. You can see here, not a huge difference, but still a notable difference in terms of lifetime risk for women versus men among cognitively normal 65-year-olds. And of course, genetics is a big part of the picture here too. So let me say a little bit more about genetic risk factors. Some of you may know that there are some rare genetic mutations that are very highly predictive of Alzheimer's. So if you ever saw the film Still Alice, where Julianne Moore won an Oscar for portraying, I think she was about a 50-year-old woman dealing with this. That's the type that she had. And so in these cases, people who have these rare genetic mutations that are, passed down usually from one generation to the next, they will almost inevitably develop Alzheimer's. Fortunately, these are very rare. I think it's thought that maybe just like 1 or 2% of all Alzheimer's cases are in this subtype. But when you have these kinds of mutations, the disease often develops much earlier than we typically see, even into one's 30s, for example, and a much more rapid disease course. So in these kinds of situations, we do have genetic testing and counseling that's available, because oftentimes, it might be like in the film Still Alice, Julianne Moore's character, her adult daughters who were in their 30s, they were trying to figure out, should we be tested or not? And so we do see this genetic testing occurring, and this has been a very important set of findings. But from a public health standpoint, I think that perhaps the genetic risk factor that's more relevant than these rare mutations known as APP and presenilin 1 and 2, the more relevant from the public health standpoint is actually this gene known as APOE, or apolipoprotein E. So some of you may have heard of this gene. This is one that's found on chromosome 19, and we all have an APOE genotype. There are 3 common alleles, E2, E3, and E4, and we each inherit one allele from each of our parents. And so the allele that is associated with higher risk of Alzheimer's is this E4. And so we've known this actually since the 1990s, that E4 is a well-established risk factor for Alzheimer's. And interestingly, E4 is also a modest risk factor for heart disease as well. So APOE, just to give you a sense of in the general population, the E4 risk allele is actually pretty common. You can see about 25% of the general population has at least one E4. And then about 2% of the population has 2 E4, so they inherit a risk allele from each parent. So a lot of people are curious, well, what does that mean in terms of risk? And so here's, maybe this helps a little bit. In the general population, the overall lifetime risk of developing Alzheimer's is said to be about 10 to 15%. And you can see that if you have one E4 allele, you have a slightly elevated risk, 20 to 30% lifetime. But if you have 2 E4 alleles, that it goes up pretty dramatically to perhaps even over 50%. So it's a very important risk factor. On the other hand, just because you have E4 doesn't mean you're definitely going to get Alzheimer's. And in fact, we like to say it's neither necessary nor sufficient to cause Alzheimer's. And what that means is you could be E4 and never get the disease. You could also have Alzheimer's and be E3. So it's just a risk factor, not automatically determinative. So it's not used much in medical practice because of its limitations, but because there's a lot of people out there who are curious. The genetic testing company 23andMe, that some of you may know about, got FDA approval to offer APOE testing direct to consumer, because you can actually determine APOE genotype from a simple saliva sample. So what they have people do is just spit in a tube, send their test kit back, and then they allow people to learn their APOE status just via their website. And so it's been kind of controversial in terms of some in the medical community feel like we should only do genetic testing, with a healthcare provider. But 23andMe is saying, well, people with some education could handle this, learning it on their own. And so there's a lot of debate there, but as of now, APOE testing is available through commercial direct-to-consumer genetic testing. Looks like Tony's making a few comments in the chat, so thank you or Tong, excuse me, not Tony. So thanks for those comments. But when we think, so that's genetics and age and sex are all things that are pretty non-modifiable. But there's a lot of interest in, well, what are things that we can do to reduce risk that might actually make a difference? And so you can see the Lancet Commission was this international group they recently took a look at all the available evidence on risk and protective factors, and they put out this summary where these were some of the suggestions they had for reducing dementia risk, and they're kind of organized in these different boxes as opposed to like what they might map onto in terms of the way in which they might prevent dementia. And again, they're talking about dementia prevention writ large, not just Alzheimer's specifically. And some of these are things you probably have heard about before to one level or another. And they're kind of, I'm not going to march one by one here, but you can see a lot of these are things that are just good for us in general. Like we should, of course, all be stopping smoking, not just because of dementia, but because of all the other health risks it poses. Interestingly, some of these are health conditions in their own right. So things like diabetes, hypertension, or even obesity might be considered a health condition in and of themselves, but that they also then pose risk for dementia down the line. Some of these are mental health related or substance abuse related, so things like depression, alcohol. And some of these have to do with kind of just general healthy behaviors like frequent exercise or being socially engaged. So these are things, again, that are probably, we didn't need to know about dementia risk to know that we should be doing them, but they may have that added benefit of lowering the chances of developing dementia. And so what this group concluded on the basis of their review of the literature was if we could attend to all of these factors, all these 12 risk factors, we could actually prevent or delay 40% of all dementia cases. So that would be, we're talking about millions of people in the United States if we could do all of these things. So that's the good news. On the flip side, that means 60% of dementia cases would not necessarily be affected by addressing all of these. And I think that's important to keep in mind because I'm always a little bit wary. We don't want to get to the point where if someone develops dementia, then we say, oh, if you'd only lived a healthier lifestyle, then you'd be fine. And we into this like blaming the victim kind of thing. So it's I think important to point out one could be doing all the right things in terms of one's health and still develop Alzheimer's or related dementia. It's not a personal responsibility issue per se. I just wanted to highlight a couple risk and protective factors that I think are particularly important. So there's a robust literature around physical activity being beneficial to all kinds of areas of health, not just cognitive functioning, but mental health and physical health. So, and we've found this evidence both from observational studies that have linked exercise to lower risk of cognitive decline, as well as some intervention studies, some actual intervention trials where they've shown that those who are engaging in regular physical activity are looking better on brain scans, for example, in terms of their hippocampal volume, are looking better on actually memory tasks. And so just as a reminder to us all, I need this reminder myself for sure, is that the federal guidelines are such that they suggest 150 minutes a week of some kind of aerobic activity. So that's just overall. And then these data that I'm pointing to suggest that there might be some added benefit in terms of cognition. There's been some interesting recent studies looking at diet and brain health. We've known for a while that healthy foods have a lot of physical health benefits. You can see listed here that may be related to conditions other than dementia. And then interestingly, there was a recent German study that looked at adherence to this Mediterranean diet in particular. The Mediterranean diet has been a well-studied approach, for example, in preventing heart disease. But they found in this study, it also seemed to be linked to lower brain atrophy, better memory, lower levels of amyloid and tau in the brain. And so I think the Mediterranean diet is recommended for a lot of different reasons. And for those of you who are not familiar with it, the idea is, increased fruit and vegetable intake, using when you're going through proteins, thinking of things like fish as opposed to red meat, trying to limit some of the, desserts that we know are bad for us. So a lot of this, I like this graphic here, it kind of shows, different ways we could start to think about. These are kind of a lot of typical ways in the American diet that we consume foods, but can we think about these healthier alternatives? And so the Mediterranean diet is one that has a lot of research support behind it. Interestingly, the Lancet group didn't talk about sleep, but I think we are seeing more and more studies showing the importance of sleep in terms of cognitive functioning. So this UK study, they just came out with this within the last couple months. They found that those who had slept under 6 hours a night had a significantly elevated risk of dementia. And so you can see this dark line is this hazard ratio, that risk of dementia, and you can see it's much higher for those who are in this kind of 4 to 5 hours a night, as opposed to those who are getting more like 6 to 8. So again, people may differ individually. If you're someone who is totally fine with 5 hours a night, then I wouldn't necessarily think you have to like try to sleep more. But those of us who know we aren't getting enough sleep, could try to focus on this because again, like diet, like physical activity, sleep is associated with a variety of positive health outcomes if we can have good sleep hygiene. Another risk factor where we really don't know much because we're in such early days is COVID-19 itself. Although given its importance to cognition, there's a lot of debate over what about this long COVID? Does it have some potential negative cognitive effects over time? So the Alzheimer's Association has partnered with the WHO to launch this major international study where they're going to be following COVID-19 patients who've been hospitalized as a result of the disease to follow them over 18 months to see how they fare afterwards. So we'll hopefully learn more about some of these effects of COVID-19 on the brain too from this kind of study. So some of these risk and protective factors, the kinds of studies I'm mentioning are more these observational studies, but some research has moved towards more formal clinical trials to test lifestyle interventions. So I wanted to say a little bit about those. And I think it's exciting. If you take a look at the NIA website, they're the NIH institute I mentioned that funds a lot of Alzheimer's research. I think it's exciting to see just how many studies are moving beyond just drug trials to things like diet, sleep, exercise, cognitive training, neurostimulation, trying to support medical decision-making. There's a lot of caregiver interventions under development. So I think it's an exciting time for intervention research beyond just the traditional medication trials that we hear so much about. And a lot of the lifestyle interventions are kind of premised on this slogan of what's good for the heart is good for the brain. So we know now that a lot of things that are risk factors for heart disease listed here are also risk factors for dementia. And so one interesting study that kind of took this advice was the Sprint Mind trial. So this was a study that was initially designed to focus on managing hypertension. So they were taking a look at, the traditional approach in managing high blood pressure is to try to, keep it under the systolic blood pressure under 120. And so in this trial, they were trying to take a more aggressive approach. The standard care is to try to get systolic blood pressure under 140, but in this intervention, they were trying to get it under 120. And both through, there are some antihypertension medications. This can also be achieved through lifestyle changes. And so even though this approach was initially thought of in the realm of heart disease, in this trial, they were also interested, well, might it also be able to stave off mild cognitive impairment? And so this major study of over 9,000 older adults with hypertension, they undertook this intervention and they found that more aggressive approach to managing blood pressure that I was just mentioning did result in 19% lower chance of going on to develop mild cognitive impairment. And so that showed some promise of this approach as a means of delaying cognitive impairment. And so they're now going to follow up with this Sprint Mind 2.0 trial to try to take the next step. So they showed it seemed to be beneficial in lowering risk of MCI, but now they're saying, well, let's say you have MCI, could it still be useful to take this approach. And so they're going to see, will this intervention of managing hypertension have benefits in terms of whether people with MCI progress to dementia. So Lyndon saying, will I talk more about the neurostimulation approach? Not a lot in this talk, but I will say that that is one of the areas of intervention that's under active investigation at our center. So my colleague Ben Hampstead is a neuropsychologist who actually does have an actively NIH-funded clinical trial using one neurostimulation approach. And so maybe when we get to that, maybe I can jump out and kind of point that particular study out on our website. But I don't have any pre-made slides that go into much detail there. But remind me when we get to the end, I can try to point out that study. Another interesting approach to lifestyle intervention was launched in Finland called the FINGER study. So they did a major trial with older adults, again, who were cognitively normal, but at elevated risk of dementia. And here in this intervention, it was interesting. They weren't using just one approach. They used kind of a combination of lifestyle approaches. So they gave people nutritional guidance. They gave them physical exercise training. They gave them cognitive training, via like computer games that are trying to stay sharp. They monitored their vascular risk factors. And lo and behold, they found that in the intervention arm, that group scored better than the control group on a range of cognitive tasks, whether not just memory, but also processing speed, something called executive functioning, your ability to multitask. And so that was very promising. And again, these are things that are not going to have the kinds of side effects that we see with the medications that are often used, can often have benefits beyond cognition. So there's a lot of reasons for thinking about lifestyle intervention. And so these FINGER trial results were impressive enough that we now have this worldwide FINGERS network. So we have similar studies being conducted in over 25 countries worldwide, again, looking at this multi-component lifestyle approach. So more to come from that set of studies, but luckily the US is part of this worldwide network. The US version is called the Pointer study. So this is a trial that just recently launched, again, using that multimodal approach from the FINGERS trial. You can see the elements listed here. There are 6 sites nationally that are recruiting. Unfortunately, Detroit area is not one of them. Chicago is the closest site, but these 6 sites nationally are actively recruiting now for this Pointer study. And so, people often say, well, what should I do to reduce my risk of Alzheimer's? I think I've suggested some different options here. The Alzheimer's Association itself has this nice 10 ways to love your brain website. So I encourage you to check that out. So we've talked about, a lot of those elements here today. Haven't talked much about avoiding head injury. That's another feature of this plan. But again, a lot of these are just kind of common sense and things that we hopefully are thinking about no matter what our age and no matter what our health status. And just to give you a little bit more on kind of further reading, if you're thinking about if brain health is a particular area of interest, Sanjay Gupta, who you may know as the CNN chief medical correspondent, he's a University of Michigan alum as well. He has a new book out called Keep Sharp, Build a Better Brain at Any Age. And I think he does a good job of kind of sifting through the literature to say, well, what do we know? What do we not know? And so I think he provides some sensible recommendations. I mentioned earlier that Facts and Figures report from the Alzheimer's Association is another good resource you might want to check in. My colleague at the University of Pennsylvania, Jason Karlowicz, has a new book out called The Problem of Alzheimer's. This is more kind of a historical view of research and its development. And he'll actually be coming to Michigan in November to give a talk here and do a book signing at Literati Bookstore in Ann Arbor. So stay tuned for that event. But these are just some resources. Certainly this is not an exhaustive list, but this kind of highlights some of the themes that we've talked about today. And so another area in terms of sneak previews of coming attractions is this Alzheimer's Association International Conference. And so this is scheduled for late July. It was initially scheduled for Amsterdam. I'm not sure exactly how they're going to handle the COVID restrictions, but one way or another, the conference is taking place. And so I'd encourage you to keep an eye out, because oftentimes, major breakthrough findings are reported there, and they make the national news. And then I did want to put a plug in as we close here for research here in Michigan. We're fortunate enough, as Susan mentioned at the outset, to be one of the NIH-funded Alzheimer's disease research centers across the country that work together. So we, as I mentioned, do a lot of different Alzheimer's studies. Some we conduct ourselves. Some we're like supporting other researchers who are looking to recruit. So here's where maybe I'll try to, if I can pull this off, just stop sharing my screen for a second, and I could try to pull up our website if it works out that I can handle this. Are you seeing, Susan, are you seeing?
Yes, your desktop.
Does it say join a study?
No.
Okay, let me try again here. Are you seeing a screen that now says
Yes, got
join
it.
us? Okay, so this is our website where we list all of our actively recruiting studies. And I mentioned Ben Hampstead earlier. Here he is. He's leading, the person who mentioned interest in neurostimulation. He has this study called STIM, Stimulation to Undermine Dementia, where they're doing this interesting intervention where they're doing non-invasive electrical brain stimulation combined with some cognitive training. So he's found that approach does seem to have some potential benefit for folks with mild cognitive impairment. And so it's an actively recruiting study using that neurostimulation that was asked about earlier. But you can see we have a whole range of studies. That AHEAD study that I mentioned, the drug trial that it's looking at people with elevated amyloid. We are a site for that project. We've got a lot of different neuroimaging studies, some observational studies, some caregiver studies. The nice thing too is that not all of these require an in-person visit. Some of these can be done remotely. So I know some people are wary about any kind of, going into some setting where they'd have to, maybe put themselves at risk for COVID. So I'm not going to march through all of them, but again, this website you can see here, I've got it. It's also in the slides. And I think I'm happy to have these slides shared so people, if you're not able to quickly write down this URL, you could still be able to access the set of studies that are actively recruiting through our center. So let me stop sharing there and maybe go back to my slides, because I think we're just about at the end here. Are you seeing my slide that says "We need your help" now, Susan?
Yes.
Okay. So, and of course, it's not just our center. I think the Alzheimer's Association itself has the trial match program. I don't know, Susan, if you wanted to put a plug in for that particular program. I know the Alzheimer's Association is justifiably proud of that.
Yes, thank you. Trial Match is a free matching tool for Alzheimer's and other dementia clinical trials. So you can go to trialmatch.com to see which studies you or a family member might qualify for based on things like your age, risk factors, where you live, that sort of thing.
Great. So yeah, if you go to alz.org/trialmatch, that's where you can find that. There, the NIH has its own national listing of Alzheimer's trials in this URL that I'm pointing to here. So a lot of different ways to get involved with research. And so I'm obviously biased as a researcher myself, but hope you might consider participating yourself or encouraging those who might be interested. Also, our center itself has a lot of our own events and activities. So we have a regular monthly e-newsletter that you could sign up for if you feel like that might be a interest. So I know I've put you through a lot here, over an hour of yammering on about Alzheimer's research, but I hope it's been useful for you. I think we do have at least a few minutes left, though, for any additional questions I wasn't able to address during the talk. So why don't I stop sharing my screen? And I think there's a couple already in the Q&A. Linda's asking about hearing loss, and I think that's a great question. There does seem to be some research suggesting that hearing loss could be a potential risk factor for dementia. So, so I think it's definitely important to address. And it's always, I don't know the exact statistics off the top of my head, but it always amazes me when I see statistics both of just how prevalent hearing loss is among older adults and how many folks have not, sought out medical care, given that we do have kind of a lot of ways to be able to address hearing loss that might be useful. Whether, I think it's a complicated picture of sometimes it's lack of access to services, sometimes it's, the stigma around wearing a hearing aid that some older adults are concerned about. So it's not treated as, it's very much an undertreated condition. So it's of course important in its own right, given that improvement of hearing can be beneficial to all kinds of areas of quality of life. But it also has been suggested that hearing loss might also put people at elevated risk of dementia down the line. John is asking about hyperbaric oxygen effects on telomeres and aging. And that is not an area that I know a ton about. So unfortunately, John, I don't think I could speak authoritatively to that question. Yeah, a good question, but I'll have to look into that more. Don't have an answer for you right now. How about other folks? Anybody else with questions related to what we've covered today? Looks like, I don't know, Susan, if it's best to have people just continue to do the chat, or if they can unmute themselves and pose the question.
John just made another comment about the question he had.
Okay. Linda's saying that this has been helpful. I'm glad to hear it, Linda. Tong is answering, what contributes to the accumulation of amyloid and tau? And I think that's where I think we don't totally know for sure, but I think that's where there's a lot of focus on these different risk and protective factors. We certainly know that the genetic factors that I mentioned are definitely related to, like one of the genetic mutations that I mentioned earlier, that almost inevitably cause Alzheimer's. One is called this amyloid precursor protein, or APP. So that we know that in those cases, there's a direct link between people who have that particular genetic mutation and then go on to develop that significant amyloid accumulation that ultimately results in Alzheimer's disease. So that would be, I think, our best answer is that we know genetics for sure is involved, but in terms of a lot of these other risk and protective factors, I think there's still a lot of active investigation to try to figure out, well, which map directly onto amyloid and tau versus which map onto other processes in the brain, like inflammation. Again, as I mentioned earlier too, there's often in folks with dementia, it's not just one pathology or another. People can have amyloid tau that's characteristic of Alzheimer's, but they could also have other vascular processes going on. So they all can kind of add up together to contribute to dementia. Other questions folks have?
I don't see any other questions yet. We appreciate everyone for joining us, and just know that you will get a follow-up email with the slides, and we'll also share a survey. If you could please complete that, we would so appreciate it. And Also, if you attended today or the presentation on Wednesday, you might be a lucky winner of a gift card. So we will announce those winners on our social media channels on June 1st. And it looks like we got a couple more questions in there now.
Yeah, Linda's asking about Angiocatamab. How soon would it be? I think it would be pretty soon. I don't know. I guess the question is, I think people's waiting would probably, to me, the biggest challenge in access is often, we know that at our specialty clinics where neurologists and memory specialists, there's often a big waiting list. So I think it might be more of a challenge to get that appointment as opposed to the wait for the drug itself. But then, it's possible that even primary care physicians could, if they had a patient with an Alzheimer's diagnosis, could administer that. So I don't think it would be a huge. I don't know the exact specificity of time, but I think it would be pretty rapid fire because, as you might imagine, the drug company is also going to be very excited about marketing and disseminating the medication. Eileen is asking about how does a fall cause dementia, and it kind of depends on the nature of the fall, like where just how severe the injury is, where the head injury occurs. But you're right to certainly point out that head injury itself can be a risk factor for dementia. And we certainly know sometimes head injury is talked about in the context of another type of dementia beyond Alzheimer's. Some of you may know about CTE, which is this type of dementia that's common in contact sports athletes. So a lot of the NFL football players who've had multiple head injuries, and not even like to the point of concussions or losing consciousness, but that kind of repeated stress of being in a contact sport can result in higher risk for CTE. So that would be a dementia that it's not Alzheimer's. It's a different type, but it is head injury can be a prominent cause. And then head injury, though, is also a potential risk factor for Alzheimer's. But I think it can. I think you would want to know it's more likely to lead to dementia if it's A, like a very severe head injury, and B, if it's not just a one-time occurrence, if there are kind of repeated head injuries over time. So a lot of times physicians will try to ask a lot of details about the nature of the head injury as part of their evaluation process. All right, well, I hope I've answered your questions and provided you some useful information here. I really appreciate you. Like I said, it's a beautiful sunny Friday, so I know it's tempting to not want to be on Zoom, but I appreciate you staying focused and with me for this talk. And thanks to the Alzheimer's Association for giving me the opportunity. So take care and have a great weekend, everybody.
Thank you.